Okay, thank you. Are you able to see my screen?
Yes, and we hear you perfectly well, Jennifer.
Okay.
Thank you.
Perfect. Let me get this. So thank you, Dr. Fox. You set that up very nicely. I hope that I can highlight what we do here in Gamma Knife in terms of treating AVMs. But let's start with how does radiation work? So when we deliver radiosurgery, the radiation actually damages the DNA in the endothelial cells. And over time, that leads to deposition of fibrin, hyaline, collagen, and that gradually narrows the vessels and leads to eventual occlusion. But that process takes time, and that time course is really dependent upon the rate of endothelial cell turnover, which can be months to years. And so we typically see the radiation work gradually over a period of 2 to 3 years after we deliver the treatment. Dr. Fox did a nice job highlighting some of the limitations of the Aruba trial. And this is another study that goes along those same lines, comparing patients that had radiosurgery that would have been Aruba eligible, meaning they had unruptured AVMs, and compared it to the untreated arm of the Aruba trial. And so you can see in the graph that if you look at the 3-year mark, the risk of stroke and death was very similar between the two arms, but it really separates when you start to follow these patients over time. And that risk of hemorrhage or stroke or death in the radiosurgery arm really levels out, and there's a very low risk of that after those patients have been treated beyond about 3 years after radiosurgery. The risk of developing a complication from the radiosurgery, again, is within that first kind of 6 months to a year after treatment. And that risk is really only about 2% if you take all this group as a whole. And so I do think that there is a subset of patients that really benefits from treatment over medical management. The challenge, though, becomes in selecting the best modality to treat these patients. And as Dr. Fox highlighted, it really requires a multidisciplinary discussion, because when you compare surgery and SRS, there are some clear advantages and disadvantages to each approach. Looking at it as a whole, this group did a matched cohorts comparison and matched for all the different variables that we normally think about in AVMs. And the risk or the chance of cure or obliteration was much higher in the surgery arm, 98% versus 72%. But the risk of a deficit was higher in the surgery arm compared to radiosurgery. The risk of hemorrhage was a little bit higher in radiosurgery versus surgery, but again, that's expected because the risk or the chance of obliteration was a little bit lower. So I think it's important to have a discussion between all the different modalities to determine how to best manage these patients. Patients with a grade 1 or 2 AVM are patients we would typically consider for surgery, but there are certain situations where they would benefit from radiosurgery, and the chance of cure or obliteration with radiosurgery for these very small AVMs is actually very high, with about 90% chance of cure at 5 years. And after that first year, the risk of hemorrhage really becomes negligible, and the risk of injury is only about 2%. This is the second case that Dr. Fox polled everyone, is the 21-year-old that presented with some memory changes. And we ultimately decided to do radiosurgery for her. She had a deeper lesion. It was involving the hippocampus, and to surgically remove that would have some risk. But I think with radiosurgery, we were able to very tightly target that lesion and have a very good chance of curing her AVM over time. She's about 6 months out from treatment and is doing very well. Our chance of cure is very dependent upon the dose that we give. And so if you look at the shape of the sigmoidal curve, you'll notice that once we get to about 22, 24 gray, our chance of cure is in the 90% or 95% range. At the same time, our risk of injury is also dependent upon the dose that we give. And there's been many factors looked at it to try to determine what would predict the risk of injury. And the 12 gray volume is one factor that we found to be predictive. So if you look at this picture, the yellow line is actually the treatment isodose. That's the dose that we gave to the AVM, but the green line is the 12 gray line. And so we look at that volume to help us predict what the risk of injury would be when we deliver radiosurgery. that risk is also dependent on the location of where we're treating. And so if you're treating a deep lesion like in the thalamus or the brainstem, that risk is very dependent on the volume of what we're treating and the dose that we give. But if you're treating in the frontal lobe or the temporal lobe, we can actually treat fairly sizable lesions with a very low risk of injury. We often get AVMs in difficult locations like the basal ganglia, the brainstem, but we can be very effective in treating those with radiosurgery. So if you look at the graph on the left, that's from a study looking specifically at basal ganglia and thalamus lesions, and the graph on the right is looking specifically at brainstem lesions. And for both, the chance of cure with radiosurgery was in the 65 to 70% range, and the risk of injury was in the 5 to 10% range. But if a patient hemorrhages in this location, the effects can be devastating. So I think this is a very acceptable measure and outcome for treating these deep lesions. Here's an example of one that we did in the basal ganglia. So this was a 32-year-old female who presented with cognitive changes and a headache, and her imaging showed a right basal ganglia grade 3 AVM. And it was kind of immediately next to the internal capsule, and would have been a high risk surgically, but it was a very small volume AVM. And so I was able to treat it to 22 gray, which is going to give us a very high chance of a cure with radiosurgery and a very low risk of injury. And she's also about 6 months out and doing very well. Large AVMs can be difficult because when you think about radiosurgery, you generally think about 3 centimeters as the maximum target for radiosurgery, but many of these lesions are much larger. So this is an example of one that measures over 4 centimeters in multiple directions. But what we found is that we can do a staged radiosurgery procedure. So we'll start by treating the deeper portion, and then we'll come back 3 to 6 months later and treat the more superficial portion. And by doing that, by staging that, we're able to reduce the 12 gray volume, which if you remember was very predictive of the risk of injury. The success of staged SRS is it's a process. So if you look at the initial obliteration rates, it's actually on the lower side. About a third of patients will have success with the first round of staged SRS. But I think the more important part is that they actually have a very good response. And in the majority of patients, about 80% of patients, you'll see that the overall size of the lesion decreases by about 75%. And so at that point, you get to a very manageable size, and you can do a repeat course of radiosurgery, or sometimes they even become surgically resectable. And so if you follow these patients over many years, you'll find that by about 10 years, the cure rate becomes closer to 80%. So it's very important in counseling these patients that this is a process, and the initial treatment may not be our final answer. We may need to do additional treatment, but over time, we can really reduce the risk of them developing a hemorrhage. So this is the first case that Dr. Fox polled, and it was a large AVM that we staged. The initial volume was 17 cc's, and we did some initial embolization first to try to reduce the size. But what you can see in the top picture in the center, that was our initial stage of SRS. And then we came back 3 months later and did a second stage of SRS. And there is overlap, but the overlap is always in the AVM. But this patient is now 3 years out, and you can see on the post-SRS angiogram that they had a complete response, and they've essentially had a cure of their AVM. Now, we do most of our treatments on the Gamma Knife Icon. Icon is the newest version of the Gamma Knife. And what's different about the newest version is it has this CT arm. And so it allows us to take a CT while the patient is on the table. We need to make sure the patients are immobilized. And for complex lesions like AVMs, we typically would do that with a head frame. But we also have the option of using a mask for patients that are getting treatment. We use multiple different types of imaging to localize the AVM when we're doing the radiation planning. Probably the most useful is the CT angiogram, but we also use MRI to help us with anatomic boundaries. We can also use an angiogram. So we have the head frame placed, and then we have a box that goes over the head frame that they wear during the angiogram. And then when you take the angiogram pictures, you can see these little marks on the angiogram, and that will help us localize the 2D pictures onto our 3D images. So on this picture, you can see I outlined the AVM on the angiogram. And then I was able to put that onto our 3D images. And you can see where that intersects is where the AVM actually is. And so that's another way to help us localize for our radiosurgery treatment. We don't always need an angiogram, but particularly in patients that have had prior embolization, or they have a very diffuse nidus, or they've had a recent hemorrhage, the angiogram really helps us in outlining the area we need to treat. One of the questions that we've always debated is there a negative impact from embolization prior to SRS? And in many studies, it's been shown there is perhaps a negative impact, but I think this study did a very good job comparing. They did a matched analysis of patients that had embolization and radiosurgery versus those that just had radiosurgery alone. And they actually showed there was no difference in AVM obliteration. It was similar between the groups. The risk of injury, similar between the groups. In terms of radiation-induced injury. And then there were more complications related to the embolization in the patients that had embolization. So this study showed that there wasn't really a difference in outcome. But I will point out with this picture in the top right that it's very difficult for me to outline the area that I need to treat in patients that have had embolization before radiosurgery. This is another example of a case that we did where we did radiosurgery first and then did embolization afterwards. So this was a 19-year-old that presented with headaches and blurry vision, and she had bilateral papilledema on exam, felt to be related to venous congestion from the AVM. And so we did radiosurgery first to the AVM, and then about a month later, we went back and did embolization of several arterial feeders in hopes that it would help the venous congestion and help her symptoms. And it actually did. And several weeks after the embolization, she had an improvement in her headaches, as well as her visual symptoms. And then you can see it 2 years later, we can see the embolic material, but the AVM is now gone. And so I think in patients where there may be a benefit to doing embolization, particularly for symptomatic reasons, it's very helpful for us to be able to do the radiosurgery first and then come back a few weeks later and do the embolization. Patients do have improvement symptomatically after SRS. The graph on the left is looking at headaches. The graph on the right is looking at seizures. And in patients that presented with headaches, about 70% had a reduction in their headaches with time after radiosurgery. And the same applies to seizures. About 58% of patients were actually medication-free after obliteration of their AVM from radiosurgery. One common finding after radiosurgery is that we'll see radiographic changes on the imaging. We can see swelling around the area that we treated in about a third of patients. So that's not unexpected. The majority of those patients are asymptomatic and don't require any treatment. It will simply resolve with time. But about 9% of patients can develop symptoms. Most of the time that's temporary, with only about 4% of patients having permanent symptoms secondary to radiosurgery. There are a few rare complications that can happen after SRS, one of them being a cyst formation. So in this study that looked at over 1,000 patients, the rate of developing a cyst after radiation was about 1.5%, and that's a very long-term risk. So we typically see that 10 years after radiation. And then one of the more feared complications is radiation-induced malignancy or tumor after radiation. And this study specifically looked at radiosurgery for AVMs. And after 10 years, that risk was just over 0.5%. So it's a very, very low risk, even though it is a possibility. The most common histology that we see after radiation is meningioma, but there have been reports of things like a high-grade glioma following radiosurgery for AVMs. So I hope that I've highlighted some of the things that we can do with Gamma Knife. This is one of my favorite things to treat because we have that delayed gratification. We have a great multidisciplinary team here, and so I think our team does a particularly good job at looking at each modality and trying to find the best fit for each case.
Thank you, Dr. Peterson and Dr. Fox. Impressive results, impressive cases. I put a quick question just to kick it off. So for people who are here, and I'm sure there are more questions, prediction. We know for brain cancer as well that some patients respond so vigorously against radiation, a lot of inflammation. a lot of side effects and so on and so forth, and potentially even brain, as you said, edema and eventual encephalomalacia. How do we know which patients are going to, potentially result in a positive response in these AVMs? Are there any predictors? Are there any opportunities to potentially look at predictors through a study that you guys can lead in the future? That's a big question right here.
Mm-hmm. Well, there are certain known factors. So things like the size of the lesion, the location of the lesion, those are kind of known predictors of radiation injury. But then there's some patients that, like you mentioned, are just more susceptible to radiation injury. And those are very hard to predict up front, particularly in patients that's never had exposure to radiation.
And then I'm going to ask Chris, and then I'm going to ask Henry. I see Henry raised as to whether or not he has any ideas with the recent study that we're doing with a group from Mexico. But, Chris, anything to comment? And then Thean has a question.
Yeah, I mean, I think that's a great question, and perhaps something we could look at, as a sort of overlap between brain tumor and radiation for AVMs, which is probably what Henry's going to comment on. But other than the size of the lesion and how much dose we can deliver, as Jennifer mentioned, a lot of this is just based on retrospective analysis, coming from centers with huge volumes like Pittsburgh. So a way to, potentially use artificial intelligence or, other non-invasive biomarkers to predict this would be great. But there's nothing like that exists at this point in this space.
I think there's a lot of work being done in that regard, though. Some of my colleagues in here in Florida are looking at biomarkers in cancer patients that could predict risk of radiation injury. And then, Dr. Vibute has been very interested in looking at biomarkers that could predict specifically related to brain injury biomarkers. But that work is still kind of in progress. We don't have that available yet, but I think it's coming.
And just to refresh your memory, Jennifer and Chris, our department holds, now we are beginning to get a lot of traction from other people within Mayo, because we have one of the most thorough and vigorous human biobank for brain, for blood. You guys may not be aware, but we have over 1,000 patients in our biobank with blood, every single one. So this is, of course, now that the enterprise is beginning to get a hold of that, and we've been getting requests for this tissue, that tissue, and so on and so forth. But every single one of our patients that supports a lot of our NIH grants in the department have human, blood collected, So just to put it right there, I see Thean, Robbie, and then I'm going to ask Henry for a comment. Thean, go ahead.
Yeah, I just want to say that's a fantastic talk and very impressive results. And just following up on everybody's comments about prediction, it'd be fantastic to, and as you were just saying, Dr. Peterson, with with the work that Dr. Vibhuti is doing, he's also looking at the 4D flow on the 7T MRI. So I think looking at the flow of these AVMs and the angioarchitecture, all these things, as well as the personalized, genetics of the patient, could help predict the response. So I think we're building the capacity to image these patients very carefully. So, I would encourage, if you have an AVM, to send them in for MRA 4D flow, because we are building that expertise here.
I love it, Dan. And what I would encourage also, Chris and Jennifer and anybody who's involved in this patient, is that maybe a lot of them we don't operate, but some of them operate. But anybody who we operate, we should potentially consider amending our IRB to be able to collect blood on those patients as well. Even the ones that only have radiation and don't have surgery, because that's part of the study. That's an expense, and it is expensive. I know I tell people, out of our department, we spend on average anywhere between $600,000 to $700,000 a year to maintain this biobank. But I felt that it was important. We started doing it. We brought over 2,000 samples from Hopkins. Those are another 2,000 samples that we have, because I always felt that's what it supported my NIH-funded work for many, many years. And now the NIH-funded work with many people in the department. So, Robbie, take it away.
So first of all, this is definitely, as Chris started, it's an opportunity for improvement. And as you said, Dr. Quinones, because those AVM patients are left with, it's really tough, especially for us who started treating those lesions a long time ago. And you know the results for most of those treatments, but the Aruba kind of blew what we know about AVM. And it's the most confusing meeting with any patient with AVM, because you're sitting with those patients and then you tell them, you know, they come with very high expectations and you sit in front of them. This is where you say, I really don't know how to treat you. And that's the reality after the Aruba. So our team, I kudos to Jennifer and Fox, you know, to look at this basically from a more, you know, opportunity perspective. And I think definitely there is an angle that every department should take. And I see lots of patients. Lately, I saw patients, and then I said, Chris, take a look, because I just don't see that I should be operating on this patient. I mean, I love to do surgery, but you gotta put the need of the patient first. And I don't know the outcome, but Chris met with the patient and so forth. So I think definitely this is something that you know, we can make a difference, especially if we create some sort of a algorithm treatment, and you kind of revisit this in the area, saying, you know, this is how our algorithm is lined up. So definitely an opportunity for clinical practice. You identify the opportunity for research with blood bank, because this is those patients are born with something like this. So there is an opportunity for markers. You know, would you be able to predict the risk of radionecrosis, markers, risk of bleeding based on those markers? So there's definitely an opportunity for that. And the last thing I want to say is basically this is the true multidisciplinary disease that no one, and I don't see that this will change in the next probably 50 years until we kind of look at AVM differently. There is nothing that we're looking at, just like bypass surgery. Whatever we're looking at, we're just scratching the surface in terms of risk of bleeding and prediction of outcome. And somebody needs to look at it a little bit deeper, and maybe with a more complex algorithm, artificial intelligence, I don't know what it is, but whatever we're looking at, outcome and treatment for AVM might not be still the right way to look at it. So
I think there's a great opportunity here, Ravi. Everything that you mentioned for Chris, for you, for Jennifer, for Dan, to create clinical trials where not only you're looking as Tian said, the imaging, but also the biomarkers, enrolling them, decision making. I love what you guys did, segment in different regions of the AVM and things like that. I mean, I think this is a great opportunity. There's so many of these patients out there internationally as well that are, you know, struggling their management, and we know that surgery for many of those is not ideal, and we have all their tools. So anyways, I encourage that very, very much. I see some questions right here. Chris, go ahead.
Well, I was just mentioning, you know, there's you know, some early work out there for different inhibitors of pathways involved in angiogenesis and whatnot with RAS and MEK inhibitors. You know, so future generations may be looking back saying, can you believe they used to operate on these, or they used to do this or that? And then, you know, these patients in the future may just get a pill, as Robbie implied. So I agree, we're just kind of scratching the surface. The more patients we can see, the more patients we can have these multidisciplinary discussions with, you know, the more patients we can study, even if we're not operating on them, you know, is going to benefit many patients and generations to come. So
yeah, so we have the TOBAS. So we have the TOBAS trial, and we're enrolling into the arm of a registry basically. And I encourage everybody who's, you know, to send those patients for enrollment, even though our coordinators look for those. But that's the only way to look at it, probably in retrospect, how those patients do and how we figure it out. So I definitely encourage everybody to send those patients for enrollment as well.
I just thought about a study that Paola and I are communicating, Dr. Mead and I, there's a study that we're going to do. Very simple. We have over 1,000 samples of patients that we have gotten for tumors and other diseases. And some of them get radiation, and some of them, like I said, respond very vigorously. I'm going to ask Paola to do a study where we're going to put that plot and look at some of those biomarkers to see if we can identify, at least in that patient population, some of the things that make it more susceptible. So, because I know that there are some genetic signatures, and this is a study that we're doing with a group from Mexico. I'm going to ask Henry to go ahead and comment on that. Henry, comment on that study that we're doing from the group from Mexico City.
Yes.
Okay,
Yes, it's a study that is looking into the relationship of patients that have radionecrosis after radiation and how they respond to treatment in GBM in general. So they are looking for signatures that can predict the prognosis for survival using genes related to radiation necrosis.
Mm-hmm. And I think there's some other groups. So there are some potential genetic signatures that we can look at. So I'm going to ask Henry to coordinate with policy for the brain tools. But I think Chris, Robbie, Jennifer, then we can do the same thing for AVMs. As a matter of fact, there may be some patients already that we have looked into with AVMs, and we have collected tissue and or blood. So, and Paula can see whether or not there are some of them, and we can look at our biobank. But if not, like I said, a clinical trial, that would allow you guys to design something that would attract patients from around the world, because these are very complex patients. That's what will make us special in the management of this disease. All right, good. Any other questions, any other thoughts from anybody? I know we went over time, but these are very important and relevant and impressive talk and impressive results. We will send you the PDF of the update so that we didn't go through. We'll review some of the highlights for next week. I'm already getting emails of more manuscripts that are being accepted by people in the department. So we'll update and we put, and then we're going to have, of course, some of our pictures from the new residents that are coming in the month of June as well. So you guys will get a chance to meet them. So good. All right, everybody. Have a wonderful, wonderful day. Thank you for everybody for your presentation, and have a great week, okay? Gracias, Gabriel. Adiós.
Adiós, adiós.
Chao.